In this presentation, we will discuss patient education and health promotion. The learning objectives for this presentation are as follows. Explain the purpose and goals of patient education in promoting wellness and preventing illness. Describe 3 modes of learning and how each relates to patient teaching. Identify factors and barriers that affect teaching and learning. Summarize strategies for teaching across the lifespan, including children and older adults. Recognize resources that support patient education. Describe essential components of documentation for patient teaching. Explain how teaching continues after discharge through coordinated care and written plans. Assess a patient's learning needs and readiness to learn. Develop and implement an individualized patient education plan. Evaluate teaching effectiveness through feedback and return demonstration. Revise and document the plan as needed to promote continuity of care. Patient education is one of the nurse's most powerful tools in promoting wellness and preventing illness. We start education the moment a patient is admitted, not at discharge. Teaching early allows time for repetition, questions, and evaluation of understanding. Before a patient leaves the hospital, they must know how to safely care for themselves at home, including how to take their medications correctly, what diet to follow, how to perform treatments, and how to recognize when to seek help. Effective teaching can prevent complications such as medication errors or readmissions. To provide effective education, nurses first assess the patient's learning needs. This means determining what the patient already knows, what knowledge gaps exist, and how the patient learns best. Some patients learn by seeing visual, others by hearing, auditory, and many by doing, kinesthetic. Next, we consider factors that affect learning. For example, the patient's cultural beliefs, emotional state, confidence level, and readiness to learn. A patient in severe pain or distress will not absorb new information effectively, so timing matters. Once assessment is complete, nurses form a teaching plan. This plan outlines what will be taught, how it will be presented, and how understanding will be evaluated. Collaboration with other members of the healthcare team, such as dietitians, physical therapists, or pharmacists, ensures that the patient receives consistent, accurate information from all providers. In summary, teaching is not a one-time event. It's a continuous nursing responsibility that begins at admission, adapts to patient needs, and empowers patients to care for themselves confidently after discharge. Every patient learns differently, and as nurses, we need to identify how our patients learn best. The 3 primary modes of learning are visual, auditory, and kinesthetic. Visual learners process information through what they see. They benefit from pictures, diagrams, videos, or written materials. For example, showing a patient a labeled diagram of the respiratory system can help them understand how their inhaler works. Auditory learners learn best by hearing. They may prefer listening to verbal instructions, explanations, or discussions. When teaching these patients, nurses can use verbal repetition, explain step-by-step procedures out loud, or provide recorded teaching sessions. Kinesthetic learners learn best through hands-on experience by doing or touching. These patients retain information by actually performing the task, such as practicing insulin injections with a teaching model or performing a dressing change under supervision. Most people have one dominant learning style, but many benefit from a combination of all 3. When possible, nurses should use multiple teaching methods, such as explaining, demonstrating, and having the patient return demonstrate, to reinforce learning and accommodate different preferences. Identifying a patient's learning mode helps the nurse adapt the teaching plan, improve comprehension, and promote patient safety. A patient who practices a skill hands-on, hears the instructions, and sees the steps visually is far more likely to perform it correctly after discharge. This aligns with the cognitive, affective, and psychomotor domains of learning, ensuring education is both effective and lasting. When nurses prepare a teaching plan, the first step is to assess what the patient already knows and what they still need to learn. Assessment ensures that we build on existing knowledge rather than repeating or overwhelming the patient. We start by asking questions to understand the patient's knowledge of the disease, how much they truly understand about their diagnosis, what causes it, and how it affects their body. Sometimes, even patients with chronic conditions like diabetes or hypertension have gaps in understanding because no one ever explained things clearly before. Next, assess whether the patient understands the dietary needs related to their condition. For example, does a heart failure patient know how to limit sodium? Does a diabetic patient understand carbohydrate counting? Teaching must be specific to their condition. Then evaluate the patient's activity regimen or limitations. This could include exercise recommendations, restrictions, or safety precautions. A patient recovering from surgery might need guidance about gradually increasing activity or using assistive devices. Assess medication knowledge, including both prescription and over-the-counter OTC drugs. Many patients don't realize that OTC medications can interact with prescriptions or worsen chronic conditions. Ask the patient to explain when and how they take their medications to check for accuracy and safety. Finally, discuss self-care at home. This includes wound care, monitoring for symptoms, follow-up appointments, and when to seek help. Before discharge, patients should be confident and capable of performing essential self-care tasks. Once all of this information is gathered, nurses must prioritize learning needs, focusing on what is most critical for safety and immediate health outcomes first. For example, teaching a patient how to administer insulin correctly is more urgent than discussing long-term dietary planning. Remember, some patients may hesitate to admit they don't understand. Use open-ended questions and non-judgmental communication to create a safe environment for learning. This helps uncover gaps in knowledge that might otherwise go unnoticed and ensures the teaching plan is effective and patient-centered. When planning patient education, nurses must assess for any factors that might interfere with the patient's ability to learn or perform self-care. Every patient is unique, and certain physical, cognitive, or emotional conditions can become barriers to learning if not identified early. First, consider sensory impairments such as poor vision or hearing. A patient with visual loss may struggle to read written instructions or medication labels, while one with hearing impairment may miss verbal cues during teaching. For these patients, nurses can use large print handouts, visual demonstrations, or written summaries to reinforce key points. Motor limitations, like tremors, weakness, or poor coordination, can also make it difficult for patients to perform tasks such as drawing up insulin or opening pill bottles. Occupational or physical therapy consultations can help improve technique or recommend adaptive devices. Another major barrier is illiteracy or low health literacy, which is often overlooked in patient teaching. Many adults are embarrassed to admit they cannot read well. Nurses should assess comprehension by asking the patient to explain instructions in their own words, rather than simply asking, "Do you understand?" Teaching materials should be written at or below a 6th grade reading level to ensure accessibility. Cognitive impairment, from conditions such as dementia, stroke, or medication effects, can limit memory, comprehension, and problem-solving ability. In these cases, keep teaching sessions short, repeat information often, and involve family members or caregivers. Age can also influence learning. Older adults may have slower processing speed, limited dexterity, or decreased endurance. For instance, an elderly patient may need more time to practice insulin injection or wound care. Adjust the pace, simplify steps, and provide frequent reinforcement. Additionally, recognize that emotional and physical states, like fatigue, anxiety, pain, or fear, reduce concentration and retention. Teaching should occur when the patient is comfortable, alert, and ready to learn. Finally, remember that collaboration is essential. Physical, occupational, or speech therapists can assist when fine motor skills, strength, or comprehension are barriers. By assessing these factors and adapting our teaching approach, nurses ensure learning is meaningful, achievable, and safe. Before beginning any teaching, the nurse must first assess the patient's readiness to learn. Readiness refers to both emotional and physical preparedness. If a patient is anxious, in pain, or overwhelmed, learning will not be effective, no matter how well the nurse teaches. Always choose a time when the patient is comfortable, rested, and free from unnecessary interruptions. Motivation is one of the strongest predictors of successful learning. Many patients are motivated by a desire to regain independence or return home. For example, a patient recovering from a hip fracture may be eager to learn exercises that will help them walk again without assistance. When the nurse connects teaching to the patient's personal goals, such as being able to care for themselves or rejoin family life, motivation naturally increases. Nurses also play an important role in helping patients recognize the benefits of learning. Some may not immediately understand why a procedure or lifestyle change is necessary. In these cases, explaining how knowledge helps prevent complications or improves quality of life can make learning more meaningful. For instance, when teaching a diabetic patient about blood glucose monitoring, the nurse can explain how keeping blood sugar in range prevents vision loss and nerve damage. This link between learning and positive outcomes reinforces motivation. Always approach education with patience and empathy. If a patient shows resistance, explore their feelings, clarify misconceptions, and encourage participation. By creating a supportive, goal-focused environment, the nurse sets the stage for successful learning and long-term health management. When providing patient education, nurses must always consider the patient's cultural values and expectations. Culture shapes how people view health, illness, and healing. A patient's background influences what they believe causes illness, who they trust to provide care, and what treatments they find acceptable. For example, some patients may believe strongly in natural or herbal remedies and may be hesitant to take prescription medications. Others may view illness as a test of faith and rely on spiritual practices for healing. As nurses, we must respect these beliefs while still providing accurate health information and safe care. The key is to work within the patient's cultural system rather than against it. This means asking open-ended questions such as, "Can you tell me about any practices or beliefs that are important to your care?" By showing respect for the patient's values, the nurse builds trust, which makes teaching more effective. Cultural expectations can sometimes interfere with learning or cooperation. For instance, a patient from a culture that values modesty may be uncomfortable discussing reproductive or personal hygiene topics. In such cases, providing same-gender staff or ensuring privacy can help the patient feel at ease. Similarly, language barriers may affect understanding, so nurses should use interpreters rather than family members whenever possible. Effective education must also take into account religious beliefs. For example, a patient observing fasting during Ramadan may need adjustments in medication schedules or dietary teaching. Respecting these needs shows cultural competence and increases the likelihood that the patient will accept and follow the plan of care. Ultimately, culturally sensitive teaching means planning education that acknowledges and honors the patient's values. When patients feel respected and understood, they are more likely to engage, learn, and apply self-care behaviors safely. When teaching patients, it's common to find that many lack self-confidence, especially when learning new health skills or managing a new diagnosis. They may feel overwhelmed or afraid of making mistakes. As nurses, our goal is to provide reassurance, encouragement, and a sense of safety so patients feel capable of learning. Patients recovering from illness or surgery often feel physically weak and emotionally uncertain. For instance, a patient newly diagnosed with diabetes might say, "I'll never be able to give myself insulin." When we hear this, it's important to respond with empathy. Remind them that learning takes time and that you'll teach them step by step until they're comfortable. One of the most effective strategies for overcoming fear is to break down teaching into small, simple steps. Instead of presenting a complex procedure all at once, focus on one task at a time. For example, teach a patient how to draw insulin into a syringe before moving on to the injection technique. Each time they master a step, they gain confidence and competence. It's also essential to assess what the patient already knows. Many patients have prior experience caring for themselves or others, and you can build upon that knowledge. Ask open-ended questions such as, "Have you ever done something like this before?" Or "What steps are you already familiar with?" This helps you tailor teaching to their skill level, preventing frustration or redundancy. Confidence grows through success and positive reinforcement. Each small success helps patients believe in their ability to perform self-care. Always acknowledge progress. Phrases like, "You did that perfectly," or "You're getting more confident each time," go a long way toward motivating continued effort. Finally, remember that confidence and ability vary by age and background. Younger patients may learn best through demonstration and hands-on practice, while older adults may need more time to process instructions. Adjust your teaching pace accordingly, and never assume that all patients are literate or have the same learning capacity. The key is patience, encouragement, and consistent support. When teaching older adults, nurses must recognize that aging can affect vision, hearing, memory, and processing speed. These changes don't mean the patient can't learn. It simply means we must adapt how we teach. Start by providing good lighting and printed materials in large type. Older adults often experience reduced visual acuity, making small print or dim lighting frustrating and discouraging. Encourage them to wear their glasses and ensure lenses are clean. Similarly, remind patients to use and properly adjust hearing aids before teaching begins, as even mild hearing loss can make it difficult to process new information. When speaking, use short, clear sentences and avoid rushing. Pause frequently to give the patient time to think and process what has been said. Many older adults need extra time to absorb information, especially if short-term memory or attention span is reduced. Keep medical terminology simple and clearly explain any necessary terms. For example, instead of saying hypertension, you can say high blood pressure. Avoid overwhelming the patient with complex explanations. Throughout the session, ask questions frequently to assess comprehension. Simple checks like, "Can you tell me how you'll take your medication at home?" help the nurse gauge understanding and retention. Encourage questions and give patients plenty of time to respond. This builds confidence and ensures they feel respected rather than rushed. Repetition is key. State the most important points at the beginning and again at the end of teaching. This helps reinforce learning and strengthens memory. Providing written reminders, medication charts, or visual aids can also help patients remember instructions once they return home. Additionally, encourage memory support such as medication organizers, checklists, or schedules posted in visible areas like the refrigerator. These tools promote independence and prevent errors. Remember, older adults often have rich life experiences and established routines. When nurses teach with patience, respect, and adaptability, learning becomes achievable, and patients feel empowered to manage their own care safely. When developing a patient education plan, nurses use the same systematic and collaborative approach as they do for other parts of the nursing process. The teaching plan serves as a roadmap for what the patient needs to learn, how it will be taught, and how learning will be evaluated. The first step is to analyze assessment data. This means reviewing what we already know about the patient's physical condition, cognitive ability, emotional readiness, and preferred learning style. Assessment findings help us identify learning needs and potential barriers to understanding. Next, the nurse establishes behavioral objectives. Behavioral objectives are specific, measurable statements that describe what the patient will be able to do after teaching. For example, instead of saying the patient will understand insulin injections, a behavioral objective would be, the patient will correctly demonstrate how to draw up and inject insulin using a septic technique. These objectives are clear, time-bound, and patient-centered. They represent real behavior change or skill acquisition that is meaningful to the patient. After identifying the goals, the nurse creates a teaching plan that outlines the methods and materials to help the patient meet those goals. This plan should include content, teaching methods, such as demonstration or printed handouts, timing and evaluation criteria. Teaching should always be delivered in small, manageable parts and reinforced through repetition. Patient education is most successful when developed collaboratively. Nurses should include input from other healthcare professionals involved in the patient's care, such as dietitians, physical therapists, occupational therapists, or pharmacists. For instance, a diabetic education plan may involve nutrition teaching by a dietitian and medication instruction by a nurse. This teamwork ensures consistency and helps the patient see how each piece of education connects to overall health outcomes. Finally, consistency in teaching is critical. All members of the healthcare team should reinforce the same information to avoid confusion. When patients receive clear, repeated, and coordinated instruction, they are more likely to master and retain new information, leading to greater independence, adherence, and confidence in self-care. When providing patient education, nurses need to know what resources are available to support learning both inside and outside the healthcare setting. Good teaching doesn't stop at discharge. It connects patients to ongoing sources of accurate and reliable information. Start with printed and audiovisual materials such as books, pamphlets, and videos. These tools can reinforce what was taught in person and help patients review information later at their own pace. Large print materials are ideal for patients with visual limitations, and demonstration models or hands-on equipment like inhaler devices or wound care kits allow patients to practice safely before going home. Next, be aware of local government and community agencies that provide free or low-cost educational materials. Public health departments, senior centers, and community wellness programs often have resources about disease prevention, nutrition, smoking cessation, and chronic illness management. Many of these materials are available in multiple languages and are tailored for different literacy levels. Hospital social workers and patient representatives are also valuable partners in education. They can help connect patients with support groups, home care services, transportation assistance, and counseling programs that reinforce long-term wellness. Collaboration with these team members ensures that patients continue receiving guidance after discharge. Lastly, the internet offers a wide variety of educational resources, but nurses must teach patients how to identify credible sources. Reliable websites include those ending in .gov, .edu, or .org. For example, the Centers for Disease Control and Prevention, CDC, or the National Institutes of Health, NIH. Patients should be cautioned to avoid sites promoting unverified treatments or products for sale. By connecting patients with trustworthy educational resources and teaching them how to evaluate information critically, nurses empower patients to become informed, active participants in their own care. Once the patient education plan is developed, the next step is implementation, actually carrying out the teaching. Effective teaching depends on timing, setting, and the nurse's ability to connect with the patient in a calm, focused environment. Teaching should be scheduled for times when the patient is alert and free from distractions. Avoid times when visitors, physician rounds, or procedures are occurring. Learning is less effective when patients are tired, anxious, or preoccupied. Nurses can teach one-on-one or in a group setting, depending on the topic and the patient's preference. One-on-one sessions allow individualized teaching, while group sessions can provide social support and shared learning experiences, for example, in a diabetes or cardiac rehabilitation class. Before beginning, ensure the patient is comfortable. Pain should be managed, positioning should be appropriate, and basic needs like hunger or toileting should be addressed. When patients are physically and emotionally at ease, they are better able to concentrate and retain information. Teaching sessions should be short and focused, usually 15 to 20 minutes at a time, especially for those who tire easily or have difficulty concentrating. For complex skills, such as wound care or insulin administration, teaching may need to occur over several short sessions to reinforce learning. Always involve the patient actively in the process. Education should be interactive, not just a lecture. Encourage questions and allow the patient to practice new skills. The nurse demonstrates the procedure first, then guides the patient through a return demonstration, step by step. This approach ensures understanding and helps identify areas that need reinforcement. Sometimes teaching can be incorporated into daily care. For example, while performing a dressing change, the nurse can explain the purpose of each step and have the patient assist by gathering supplies or observing wound changes. This real-time teaching helps the patient associate learning with actual care activities. Finally, provide written or printed materials that summarize key points. These serve as a reference once the patient goes home and reinforce what was learned in the hospital. Written instructions also support family caregivers who assist with self-care at home. Reinforcing education with written materials ensures continuity, consistency, and confidence in following the care plan. The final step in the patient education process is evaluation. Evaluation allows the nurse to determine whether the patient actually learned and can apply what was taught. This step is essential because teaching is not complete until learning has been confirmed. Evaluation begins by obtaining feedback from the patient. This can be done by asking open-ended questions like, "Can you explain in your own words how you'll take your medication at home?" Or "Show me how you would check your blood sugar before breakfast." These techniques allow the nurse to see if the patient has understood the information or can perform the skill correctly. A return demonstration is one of the most reliable ways to evaluate learning, especially for psychomotor skills. For example, if you have just taught a patient how to change a wound dressing, observing them perform the procedure provides direct evidence of learning. It also allows the nurse to correct errors immediately and reinforce proper technique. Verbal feedback is equally important for assessing cognitive understanding, the knowledge component. Patients should be able to explain why certain treatments, medications, or dietary changes are necessary. When patients can verbalize the reason behind the care, it shows they understand rather than just memorize steps. If evaluation reveals that the patient still struggles with a concept or skill, the nurse should revise the teaching plan. This might mean using a different teaching method, providing simpler instructions, or breaking the task into smaller steps. Learning should always be individualized and paced according to the patient's ability and readiness. Remember, effective teaching is a two-way process. The nurse teaches, evaluates, adjusts, and teaches again if necessary. Successful patient education leads to improved self-care, fewer readmissions, and greater confidence for the patient in managing their health after discharge. Documentation is a vital part of the patient education process and a legal responsibility of every nurse. If patient teaching is not documented, it's considered not done, even if you actually perform the teaching. Documentation serves as both a communication tool and legal protection for the nurse and the facility. Every staff nurse is responsible for recording patient teaching in the medical record. Many facilities use a patient education flow sheet or electronic charting system, which helps standardize documentation. These forms ensure that key teaching topics, such as medication administration, diet, wound care, or discharge instructions, are consistently recorded. When charting, the nurse's notes should include 3 key elements: the specific content taught. For example, patient instructed on proper use of incentive spirometer, including frequency and breathing technique, the method of teaching used. This might include verbal instruction, written handouts, demonstration, or audiovisual materials. Evidence of evaluation with specific results. This shows whether the patient understood or successfully demonstrated the skill. For example, patient correctly demonstrated insulin self-injection after verbal and physical guidance. Teaching often happens informally, for instance, while giving medications or assisting with hygiene. Even when education occurs in small moments during care, it must still be documented. Consistent charting allows the entire healthcare team to know what the patient has already been taught and where reinforcement is needed. Accurate documentation also protects the nurse legally. If a patient later experiences complications, clear teaching notes can demonstrate that appropriate instruction and follow-up were provided. In addition, documentation supports continuity of care, helping future providers build on what has already been taught rather than repeating or overlooking important information. In summary, if it's not documented, it's not done. Effective teaching must always be followed by accurate, timely, and factual documentation that reflects what was taught, how it was taught, and how well the patient learned. As nurses, one of our most important responsibilities is ensuring that patient teaching continues after discharge. Effective discharge planning starts at admission and includes coordination among everyone involved in the patient's care. Before a patient leaves the hospital, the nurse should identify and communicate any specific learning needs, such as wound care, medication management, diet restrictions, or equipment use. These needs should be shared with the patient, their family or significant other, and members of the healthcare team to ensure continuity of care. Collaboration is key. The primary physician's office, home health services, and family caregivers all play vital roles in continuing education after discharge. For example, a patient discharged with a new colostomy may receive teaching in the hospital, but follow-up education at home will be carried out by a home health nurse. Sharing detailed teaching notes or electronic documentation ensures that everyone involved reinforces the same instructions. It's important to remember that some patients are discharged before all necessary learning is complete, especially in today's healthcare environment where hospital stays are shorter. To bridge this gap, nurses should make follow-up phone calls to the home health agency or physician's office. This communication helps verify that the patient received ongoing education and that any remaining questions or problems are addressed. A printed discharge plan must always be sent home with the patient. This plan should clearly summarize medications, diet, activity restrictions, follow-up appointments, warning signs to report, and any step-by-step procedures the patient must perform. Written instructions support patient safety, improve adherence, and serve as a reference for family members providing care. In summary, successful coordination during discharge planning prevents confusion, reduces hospital readmissions, and promotes patient independence. Patient education doesn't end when the patient leaves the facility. It transitions smoothly into the home and community setting through effective teamwork and communication. This ends the presentation. Thank you.